Hi, and welcome to the Expert Perspective series from Hexarad. My name is Jaymin Patel. I'm the co-founder and chief operating officer at Hexarad and a consultant radiologist by background. We're going to talk about imaging of the emergency abdomen and what the surgeon needs to know. I've got the wonderful Mr. Karim with me here today. Ahmed, would you like to introduce yourself?
Hi, Jay. Thanks for inviting me. My name is Ahmed Karim, consultant, general and colorectal surgeon, specializing in robotic surgery and emergency on call. It's working at St. George's University Hospital, which is one of the level 1 trauma centers in London. So high emergency workload, and so a good opportunity for us to discuss these cases.
Cool. So really excited to kind of spend the next 15, 20 minutes talking through some cases with you and asking all those questions that I never thought I could ask and finally kind of getting answers for them. So before we kick off, I just kind of wanted to kind of ask, what are the things you like, things you don't like about a radiology report when you have to kind of look through it, and particularly in the emergency setting?
I think if I take one step before that question, I would say radiologists and radiology team need to realize how valuable your input is and how much we rely on what you say. And therefore, important things are definitive terminology.
Yep.
And we're obviously very conscious that in this current day and age, we have different radiologists. I can't always have my favorite guy or my guy I went to medical school with being the guy to report. So standardization is important. So I'm looking for, while it may not be the name that I recognize, the format, and that's really important. And I think that's something you guys as radiologists can really help us in our decision making.
I think that's a really interesting point. And when you talk about format, do you think that relevant positives and relevant negatives are things that are something that you want in a report? Or I suppose, what format could we deploy or use that makes you feel, as you read it, reassured?
I think to make sure that it's accessible to all levels, so a consultant would be more positives and negatives.
Yeah.
But if my registrar is on call, their brain probably works in the anatomical setting. So solid organs, viscera, the anatomical layout, upper abdomens, and so that's how some of the reports are done. And I think their brain tends to work a little more along those lines. So to make it accessible to everyone, that kind of standardization anatomically probably works a lot better.
That's a really interesting point, because I think when I report acute abdomens, I sometimes forget who exactly it's going to be read by. I assume the surgeon will read it, but actually also, when I say consultant surgeon, I mean, but also the registrar, or even maybe someone more junior in the surgical team, and even the ED, the emergency department doctors will probably also need to interpret, understand, and have some actionable kind of events as a result of the report. Okay, so if we kind of maybe dig into some pathologies, get down to the nitty gritty, dirty stuff. Diverticulitis.
You weren't dirty early.
So diverticulitis, common pathology we see coming from ED as a request. What are the things that you think you want to know when you see a report on a query diverticulitis things? What are the things that change how you act and what you do? What can I do?
That's a great question. In fact, I would say what we want to know is there something that means I need to operate on this patient now? Is there something that I can suggest another intervention? Or is there something we can hold fire and see how they respond to medical therapies, antibiotics, resuscitation, etc.? And what are the big words we're looking for? Perforation. But not just perforation. Is that perforation widespread? Is it contained? Is it localized? Is it retroperitoneal? Because these will change our management. Of course, we want to know how unwell the patient is, but what we're looking for is it pancolonic? Is it a big segment? We will then be able to say, all right, not for conservative measures, not for an IR drain, for example, if it's a collection, this patient then needs surgery. And does it need to happen tonight?
So let's just address some of those in specific details. So perforation, contained or widespread. What does it matter? So for us as a radiologist, a contained perforation might be, a small, well-defined pocket of gas and gunk that's sitting outside the colon, compared to seeing what we typically refer to as, free intraperitoneal gas, so beyond the kind of local vicinity and maybe less walled off. How does that make a difference?
So free intraperitoneal gas or free fluid that's spread throughout the abdomen, you then know the situation is not under control.
Okay.
The situation is ongoing. It's active. You then need to do something about that. If we have small bowel or omentum that's matted already onto it and it's sealed, that could have been happening for a few days. And we'll say, okay, let's hold fire. Let's shut the gut down, for example, for a day or two. Let's give intravenous antibiotics. So it tells us, do we need to do something now? Or is this something that's already happened and we have an option to hold fire?
And so if you see, or if I report free intraperitoneal gas, do you invariably operate? Because what I'm saying explicitly is, inferring that there is infection potentially in all 4 quadrants at that point, and so you need to do some form of washout. Is that what I'm saying when I say there's free intraperitoneal gas to you?
You are, of course, it's not the final decision, but it's definitely moving us towards that pathway.
Okay.
Absolutely. When it's free, ongoing, that's when we're saying there needs to be a strong reason not to operate.
Okay.
Or rather, by the statement you've made saying disseminated or spread around,
Yeah.
we know now the indication is operation, and we then need to justify if we're not going to operate based on that. So it is quite strong wording.
And in terms of timing, would you operate there and then, 3 o'clock in the morning, or how does that work? We talk about the CPOD list and this magical, what gets you out of bed and into the surgery, into a theatre to do your thing?
So free perforation.
Okay.
Patient being unwell.
Okay. So there's some clinical factors there
absolutely,
as well.
Absolutely. But, the nature of our work, unfortunately, is access to theatre. So there is obviously audit about time from decision to access. But once I'm told, we as a team say, all right, now is the time to theatre. If theatre's free, we'll go 2 o'clock, 3 o'clock, whatever it may be. Sometimes theatres are busy, so you're delayed on that basis.
Okay. The other thing you mentioned was length of disease, or the length of involvement of disease, particularly for acute diverticulitis. Why does that matter?
So you want to know if it's just a localized segment,
right?
You may be able to get away with a quicker, shorter operation, but if it's a big segment, I'm then going to have to mobilize that whole left colon in order to bring out a stoma.
Okay.
I'm preparing, the team for this is going to be a full midline. It may change our analgesic strategies as well. The anesthetist will need to know. I'll say, I'm probably going to have to incise up to the Ziphy sternum if we're doing an open procedure, as opposed to just a lower midline if it's a localized. So it does help influence our strategy and even mentally prepare us, knowing how much caffeine we'll need before the procedure as well.
And am I right in saying generally for left-sided or sigmoid diverticulitis that needs surgery, you would generally do a Hartmann's? Is that how it works? What determines, I suppose, maybe the question as I kind of think about it, what determines what type of operation you do for an acute perforated diverticulitis compared to another type of operation, and what could I do as a radiologist to help you make that preparation in advance?
Yeah, so things that we would look for are strategies. Are we going to try and rejoin the patient, or are we creating a stoma? The accepted outcome is a Hartmann's procedure. That's widespread and accepted practice. That's the safest, and it gets the patient out of the trouble, and then it's left to someone else to put it back together.
Yeah.
What you might find if you're on call and it's a colorectal surgeon, that colorectal surgeon may then say, actually, perhaps we can do a washout, anastomosis, and then defunction.
Yeah.
That means their second surgery is just a closure of an ileostomy. What are we looking for there? If you say there is proximal holdup and the cecum is massively distended, the other bowel doesn't look great. In fact, it's 4-quadrant feces. That is really important, because then we say, okay, we don't need to prepare the equipment for the washout. And so we just know we need to get this patient out of the hospital.
Disaster recovery at that point,
Exactly right. You need to get them safe get them off the table, because the mortality from fecal peritonitis is still high and patients unfortunately still pass away from it.